This is the third and final presentation for the atrial rhythm interpretation. It is going to cover atrial flutter and atrial fibrillation and how to distinguish between them, how to identify atrial flutter, and that kind of stuff. So the first thing we're going to cover about atrial flutter is that it is a very rapid and regular atrial tachycardia. The prevailing theory of origin, and I haven't seen anything since then, but I haven't really looked really hard, is that it comes from scarring or an enlargement of the right atrium, which actually causes an increase in automaticity of some of the cells. And because of this, you can end up with something called a Circus reentry phenomenon. So the Circus reentry phenomenon here occurs in the right atrium, and there's no limit to the entry size, to the reentry size. So you could have a macro reentry, which is a micro reentry, which is a very small reentry problem between a few cells, or you could have something like a macro reentry. A macro reentry is a much larger reentry phenomenon, and I'll explain the reentry phenomenon here in a second. But a macro reentry is a very large reentry phenomenon, which could be just as large as the right atrium itself. For example, when we talk about AV nodal reentries, it is considered a reentry circuit or a Circus reentry phenomenon, and we'll talk about that later in another presentation. So let's go ahead and discuss a little bit about the reentry. What exactly is a Circus reentry phenomenon? Basically, a Circus reentry phenomenon occurs, and this is going to be an example. This is not a reentry phenomenon right now, but what normally happens whenever cells depolarize, and we'll say that this is a pathway right here. Let's say that an area of depolarization hits this area right here. What happens is the depolarization is going to follow the area here, which is needing to be depolarized, and the impulse is going to travel all the way around through this circle right here. The problem is, or what happens is, when this area gets back to the original spot of depolarization, this red part here is an absolute refractory period. What happens is this impulse travels so quickly around this right here that whenever the impulse reaches the point of origin again, it is actually still in an absolute refractory period, which of course means if a cell is in an absolute refractoriness, it means the cell cannot depolarize again. So as you can see here, it begins here, it circles around, and when it finally makes its way back, this signal will stop. If this area is in an absolute refractoriness, it can't continue the impulse. Now, this is what happens most of the time. What happens, though, if there is a slowing of the impulse? Let's say over here, this is the initial depolarization of this area right here, and as the impulse travels down, it gets caught up right here, and it actually slows down. What happens is, and this could be because of ischemia, this could be because of enlargement or some kind of damage with the cells. There could be several reasons why the signal can slow down right here. But the important thing here is that the signal slows down. After it gets out of this area of slowing the signal down, the impulse will speed back up again. But as you can see here, the area of absolute refractoriness, or the red area, comes back around to the point of origin. Here is your point of origin whenever the impulse hit this area. What happens is, because this area slowed down the signal right here, the initiating area here has time to change from an absolute refractoriness into a relative refractoriness or a resting state. If you're in a relative refractoriness or a resting state, this means that you can respond to an impulse. The problem here is that in this Circus reentry, when the signal came through and slowed down, the area here repolarized enough to respond to another impulse. So when the signal makes its way back, now it hits here, it can continue this cycle again. And it slows down right here, and then it makes its way back up, and once it hits here again, it's resting or refractory. It can continue to circle because this area right here is ready to depolarize again. And the whole reason this occurs is because this area right here continually slows down the signal, giving these guys a chance to repolarize. So then you end up with this big circle constantly going on like this. Now this could be a macro or a micro reentry phenomenon. If this area of slowing did not exist, then it would be like the previous slide where once the signal came back here, it would stop. But because of the slowing here, the cells had a chance to repolarize. This picture does show this occurring in a clockwise fashion, but it could very well occur in a counterclockwise fashion as well. So let's talk about atrial flutter itself. To identify atrial flutter, what we want to do is we want to look at baseline. If you remember, baseline is that little baseline down here, is that little thing in between the QRS and T waves and all that stuff. This phenomenon will actually have something called a sawtooth pattern, and that's what we classically refer to it as a sawtooth pattern. Now, this pattern is considered pathognomonic, and this is kind of a cool word right here. It makes you sound really smart. It's called pathognomonic. The G is silent. What that means is if something is pathognomonic, it means that there is one sign or one symptom that can only point towards one specific problem or disease. Let me just use an example right quick that I love to use. It's called chest pain. And my question is a heart attack or an MI pathognomonic is chest pain pathognomonic for an MI? And the answer is no. Chest pain is not pathognomonic for an MI because chest pain isn't just a heart attack. What else can chest pain be? It could be costochondritis. It could be the fact that there's a bullet hole or a knife wound in your chest. It could be the fact that somebody pinched your chest or something like that. It could be a respiratory infection. It could be an esophageal problem. It could even sometimes be a like GERD or something along those lines. So just because somebody has chest pain does not mean that they can only have an MI. On the other hand, if you have a sawtooth pattern on the EKG right here, there is no other problem that you can have. You can only have atrial flutter. So if you see a sawtooth pattern, you know it's atrial flutter. There is no other rhythm that you will ever have, and that is pathognomonic. A single problem or a single symptom or sign that points to a single diagnosis, and that's all. Now officially, these waves are actually called flutter waves. They're called flutter waves, or you can refer to them as F waves. Now notice here the F has to be capital. It is a capital F waves. Lowercase f waves are actually fib waves, so you can't use any F that you want to. If you want to talk about flutter waves, you have to use a capital F. If you're talking about a lowercase f, those are called fib waves. Just remember, with these F waves here, there is no P wave, which means there can be no PR interval because there is no P wave. Normally, the best leads to determine a person that has atrial flutter is in leads 2, leads 3, AVF, and also V1. These are the 4 best leads that you can usually determine somebody having atrial flutter whenever you can see the flutter waves. So let's talk about a conduction ratio in atrial flutter. Whenever you interpret atrial flutter, you're not just supposed to put atrial flutter. There's supposed to be an E. Atrial flutter. You need to put with some kind of conduction. All of this should be in your interpretation. So what happens here, you should have your atrial and then your ventricular conduction ratio. So if you have a 1-to-1, that means you have 1 flutter wave for every QRS complex. A 2-to-1 is 2 flutter waves for every 1 QRS complex, 3 flutter waves to every 1 QRS, and 4 flutter waves to every QRS. Now this is if it's consistent. This is only if it's consistent. If it is not consistent, then you have to put something else. You actually put variable conduction. But if you always have 4 flutter waves and 1 QRS complex, then you know that it is a consistent atrial flutter with a 4-to-1 conduction. Now, if the conduction is not constant or consistent, then it is considered a variable conduction. So if you have a rhythm that has a 2-to-1, 3-to-1, 2-to-1, 4-to-1, 3-to-1, 4-to-1, and it kind of goes all over the place, then you have an atrial flutter with variable conduction. And that's what you would put here as the variable. So now let's determine, how do you find the flutter waves? And this may take some practice a little bit. In a lot of cases, you might not be able to really identify what's going on. You might just have to do a 12 lead. So what you want to do here, and this is only one method. You could use several different methods, but I'm just going to teach one. I'm not going to teach a whole bunch. So what you could do is, what I teach here is that you draw a line through the peak and you count your troughs until you hit a QRS complex. So you draw a line, through the peak, and then count the trough. So as you can see here, you draw a line here and draw a line through the peaks, and there should be a peak here, and there's a peak here. And as you can see, they already drew the lines, and you count the troughs. 1, 2, 3, QRS. So that's a 3-to-1. 1, 2, 3, 4, QRS. That's a 4-to-1. 1, 2, 3, QRS. 3-to-1. 1, 2, 3, 4, 5, and then you hit your QRS, and that would be considered a 5-to-1. So what we would interpret this is atrial flutter with variable conduction. But that's only if you draw a line through the peak and count the trough. And it makes it easier if you draw the lines when you're first doing this. As you do this more and more, you'll be able to do this without actually having to draw the lines and do all that kind of stuff. This is an artist rendition of an atrial flutter with a 2-to-1 conduction. The problem here is that you have trouble seeing this if you're not really good at reading these on a regular basis. So what we have here is a person who is in lead 2, and you can tell the QRXs are partially obstructed, are partially obstructing these sawtooth patterns in the atrial flutter right here. So what you could do is you could actually, once again, look at the troughs. You can see the troughs right here. There's another trick to do this. There's a couple of them, actually. One of the things that you can do is, if you're having trouble determining this and what's a T and what's a P, what you could do is you could do a 12 lead. Another thing you can do is you can take your calipers and measure from here to here, and then take your calipers and then move them over and see if this right here and this right here is all the exact same interval. And if you do take your calipers and do that, what you're going to find is that this marches out perfectly. You're going to find that that marches out perfectly all the way from the front side of the strip to the back side of the strip. It's going to happen. If you do that, you can say, yeah, this is more than likely an atrial flutter, and this is a consistent. You draw the lines through the peaks. There's a peak here. There's supposed to be a peak here, but it's buried in the QRS. Supposed to be a peak here, but there is a peak here. You can count 1, 2, QRS, 1, 2, QRS, 1, 2, QRS. So you know that every single one of these suckers is a 2-to-1 conduction. So you would, the overall interpretation would be atrial flutter with 2-to-1 conduction. This is the same rhythm as before, but as you can see here, in this one they removed the QRS complexes. And what you have here is you have this sawtooth pattern right here that might be difficult to tell because it's obscured by these QRSs. But if you take out the QRSs, now you can definitely see the you can see the flutter wave down here. You can see the sawtooth pattern. Now we can't do that on a real 12 lead. You can't just remove the QRSs unless you give them a medication that stops the ventricles, and that might be a little dangerous just to determine if the person is in an atrial flutter. But here's what it would look like if we had actually taken the QRSs out of the rhythm itself. So what are some characteristics of atrial flutter? Well, we do have an atrial rate, and we also have a ventricular rate. There's going to be two different rates here. Now, the atrial rate, and you can count an atrial rate in an atrial flutter, and I'll show you how to do that in the rhythms here in just a minute. The atrial rate can range from 200 up to 400 beats per minute. The ventricular rate usually ranges between 100 to 300 beats per minute. Now, what's interesting about this is that the most common conduction ratio is a 2-to-1 conduction. That is the most common conduction ratio. A lot of times it's also variable, but if you do have a constant conduction ratio, it's usually 2-to-1. The regularity, well, it'll depend on the conduction ratio. It could be regular or irregular, but it's dependent on conduction ratio. The P wave, there is no P wave. It is F waves. Now notice, although the P wave is absent and these are F waves, it's a capital F, not a lowercase f. The P to QRS ratio, there isn't one. Technically, it's an F to QRS ratio. And it could be constant or variable. Just remember that if it's constant, 2-to-1 is the most common F to QRS ratio. The PR interval, we have no P wave, so we can't have a PR interval, so it's absent. Why? Because we have F waves. Remember, capital F waves. The QRS width, this is still an atrial problem, so there are no ventricular issues right now. So we're going to say that the QRS width could be normal or could be wide. This is a cause that I got out of the book that I use for a lot of this stuff, some of the books that I use, and I kind of like it, but I really haven't committed this to memory that deeply right now. But it is a good idea to actually see something like this. It is pretty cool. What they use is the mnemonic MADRAT PPP, basically, and that's myocardial infarction, atherosclerosis, drugs. For example, digoxin is a very common one that causes atrial flutter, rheumatic heart disease, alcohol holiday heart. This is totally awesome. What happens in alcohol holiday heart is that usually people try to avoid alcohol. Sometimes they try to avoid some of the vices that people like to do, like to partake on during the year. They avoid that kind of stuff, but then whenever the holidays roll around, you have Thanksgiving, you have Christmas, you have all kinds of holidays, winter holidays and everything, where families get together. And what do families love to do when they get together sometimes? Well, they love to drink. So what happens is a lot of times whenever people aren't used to that kind of stuff, they start eating more, they start drinking more, they start maybe staying up a little later, they start taxing their body a little bit, and it could very easily send them into an atrial flutter or a fib, or they might start showing some problems that they never did show before because normally they're pretty clean, eat pretty clean, don't drink as much during the rest of the year. Thyrotoxicosis. Pulmonary embolism, that's what that is pulmonary embolism. Pericarditis and pneumonia are some of the common causes. So let's look at some rhythms here. First thing we need to do, like always, we need to start out with the rate, atrial and ventricular rates, and then we'll walk through this in a step-by-step fashion. So the first thing I want to show you is how to determine an atrial rate. Just because there are no P waves does not mean that there is no atrial rate. You can still determine an atrial rate on an atrial flutter. And let me show you how. This is a good rhythm because it actually, for one, all these little blue dots down here show you where exactly the flutter waves are. But if those blue dots weren't there, you could still determine this. So let's look down here. As you can see here, this flutter wave peaks right here on this dark line, so we can use the countdown method. Here's 300, 150, 100. Well, the next flutter wave occurs just inside of the 300 mark. Now you can do the math and actually figure out exactly what that rate is, but we're just going to go ahead and say 310 just for fun. And the ventricular rate's a little bit more difficult. Because this is a variable conduction, we can't just say, oh, well, it's a 2-to-1 or whatever. We have to look at it. Unfortunately, this is not a true 6-second strip. But from this point here to this point here is 3 seconds. So if we look at this and say 1, 2, 3, 4, we'd count it again, there'd be 80, so we could say that there's probably about 90 beats a minute here. What we could do also is we could take this right here, that rhythm or that rate right there, and then we could also take the widest QRS R interval and determine what that rate is, and we could just average it out. So I'm going to estimate it here. You can take the time to average it out. It's very good practice to do that. But I'm going to average this here and say that this is about 80 beats a minute. You can also put a range if you determine that this is 150, and what is this down here? 300, 150, 100, 75, 60, 50. So you could also put 55 to 150 beats per minute. And this is ideally, this right here is what you should do anyway because it's irregular. Anytime that a rhythm is irregular, you should always put down a range because it really shows and it illustrates how much irregularity there is in there. In this case right here, there's almost 100 beat per minute irregularity going on in there. That's kind of important. If it's 10 or 15 beats a minute, it's okay. It's not as important as 100 beats per minute irregularity. Regularity itself, we were just talking about that quite extensively. It's going to be irregular. The P wave is non-existent. It's absent. But what do we have? We have capital F waves. P to R interval is absent. Because there is no P wave, you cannot have a P to or a PR interval. Now, you could put in the PR interval, you could put your conduction ratio, but it's actually asking for a PR interval. So let's go ahead and just skip that for now. QRS complex. Can you see the QRS complex right here, and then it kind of breaks off right there? So the QRS complex looks really good. It really does. It's narrow, it's steeply angled, it's sharply pointed. The only problem I see with it is that it's pointed down, but I'm looking at V1 right here, and the QRS is supposed to be pointed down in V1. So I'm going to say that this QRS, although the rhythm looks ugly when you first look at it, the QRS actually looks pretty good. So I'm going to say the QRS complex is 0.10 second. My overall interpretation. Now, let's look where the problems are. Where are the problems? First of all, we have no PR interval. We have no P wave, but we do have F waves. So that's a problem. This is a problem. And this is a problem. This right here, not such a big deal, but if we look at our range, that's a problem right there. So now we just have to determine what is the underlying rhythm. Well, because I can see F waves, that tells me that this interpretation is an atrial flutter with variable conduction. Now, some people, there's another trick here to determine the atrial flutter. And there's another trick that a lot of people do that I'm going to show you guys right quick. What you can do in an atrial flutter like this is that you can actually turn the rhythm upside down to look for a sawtooth pattern. And if you turn the rhythm upside down, what you see here, hopefully, is this sawtooth pattern that comes down here. Now, this looks like a saw right here. If you remember that saw that the dude was carrying in that previous picture, this down here now looks like a sawtooth pattern. You can't interpret it this way because it's now upside down. But this might actually help you see the sawtooth pattern better. What I like about this rhythm strip is that this is the same patient as the previous rhythm strip. It's just in a different lead. It's in lead 2. And I really like this rhythm because this really illustrates the importance of doing a 12 lead. Interpreting rhythms is fine, and it's a fantastic skill to have. It really is. But if you see any abnormalities on a single rhythm, you have to do a 12 lead. And if you don't know how to read a 12 lead, your training isn't quite as complete as it should be. So this is a patient from the previous one, except into lead 2 instead of lead 1. The problem we have here is that, as you can see here, the F waves are not quite as prevalent as before. Even if you decide to flip this upside down, you still can't quite see flutter waves. You can't quite see a sawtooth pattern. That's why it's important to make sure that if you have any abnormal rhythm, you have to grab a 12 lead on that person. But since this is actually a previous patient, this is a different time than whenever they took this EKG or this rhythm strip. But what we can do is we know that this is a previous patient as before, so let's go ahead and count the atrial rate. Atrial rate starts, it's kind of tough to tell with that T wave in there, so we'll say it starts here, ends about here. That's about a 300 beats per minute. If we look at the QRS complexes, it starts here. There's 300, 150, so it's just about 150 beats per minute. Regularity, if you take your calipers and march it all the way across, it actually looks regular. So we're going to say regular. P waves are absent. And the reason they're absent is because there are capital F waves. PR interval is absent. QRS complex looks good, so 0.10 second. If you measure that out, you can see it starts here, ends here, so that's a 0.08 or 0.1 seconds, somewhere around in there. My interpretation, what are my problems? Well, my atrial rate is a problem, that's too fast. Ventricular rate's a problem, that's too fast. It's regular, so that's okay. There's F waves, that's important to know. Since there's F waves, there's no PR interval, but this looks good, so we don't have to worry about that. So our underlying rhythm is going to be atrial flutter, but now we have a constant, since it's regular, we have a constant F wave to QRS ratio. So we can say it's an atrial flutter with a 2-to-1 conduction. Next one here is atrial rate. It's kind of tough to tell here, but these might look like flutter waves. So what you can do is you can flip it upside down. Does that look like a sawtooth pattern? It sure does. It definitely looks like a sawtooth pattern right now. So let me flip that back around, and we can now say, so here, from here is my 300, 150, so it's just under 300. So we'll say just 290 for fun. We have a QRS up here for our ventricular rate, 300, 150, 100, so it's maybe 140. Regularity, if you take your calipers and march it all the way across, it's going to look regular. P waves are absent. And the reason they're absent is because there are F waves. PR interval, since we have no P wave, we can't have a PR interval. QRS almost looks a little bit wide, but actually no, it looks really good. It starts here and it breaks away here, so that is just about 0.10 second. So my interpretation, we have a problem up here, we have a problem with that one's a little fast, it's regular, we have F waves, which means that's absent. So because of the capital F waves here, it's an atrial flutter with, it's regular, right? So we can say that since it's regular, we have a very constant. We have a 1, 2 QRS, 1, 2 QRS, 1, 2 QRS, 1, 2 QRS. So you can see there that it's a very constant 2-to-1 conduction. Now let's look at the next one here. This one's really hard to tell. If you have this rhythm here, just based on the rate, I would do a 12 lead on this person automatically because of the rate by itself. And I need to identify what's going on in between these suckers right here, because I could see that this might be a T wave and that might be a P wave, so this might just be a sinus tach at a very fast rate. It looks to be about 150. Or it could be a reentry, or it could be a flutter, or it could be a fib. We need to find out what's going on. So this would be an excellent rhythm to do a 12 lead, but let's go ahead and interpret this sucker. So we have an atrial rate here, and it's really tough to tell. Fortunately, these little blue dots down here tell us where the flutter waves are. So let's start here, and 300, so yeah, that is like right at 300 beats a minute. Unfortunately, this is another 12 lead, or I'm sorry, this is another rhythm strip where even though you try to flip it upside down, it's really tough to tell. If you look down here, where'd my pen go? There it is. It's really tough to tell. If you look down here, these do look like sawtooth pattern. It doesn't look like the traditional sawtooth pattern like this, but it does look like that there are some points down here. Now, if you get your calipers, you can measure these suckers out right here and see exactly that they march out perfectly. So let me flip this thing back around here. So we've now kind of identified that this is an atrial flutter. Might be kind of tough to tell, but you can kind of see it. But let's go ahead and get our ventricular rate here. We start here at 300, 150. It looks like 300, 150, exactly 150 beats a minute. Regularity, and if you take your calipers and march it all the way from the front side of the strip to the back side of the strip, you actually will be very regular. P waves are absent because we have capital F waves. Because we have no P wave, we have no PR interval. The QRS complex, it looks kind of weird, but if you go from here to here, it looks 1, 2, so it actually looks like it's very narrow. It's very normal. It is small. It is a very low amplitude, but it is narrow with steep angles and sharp points, although the only problem is very short. The interpretation, as you can see here, that's the big key right there. That is, and that is, tells me something. So we have an atrial flutter. We have to put the conduction. It's supposed to be C with a line over it. We have to put the conduction. So if I know that, it's kind of tough to tell. It looks like we have 1, 2, and then a 1, 2, and then a QRS. 1, 2, and then a QRS. So that's going to be a 2 to 1 conduction. Just remember, though, this is something that I would do a 12 lead on. I would definitely get a 12 lead on this rhythm. So let's look at this one here. Initially, this rhythm may look like it has inverted P waves and ST segment depression. Kind of tough to tell. But what you're actually looking at here is a sawtooth pattern that is buried in the QRS. The second sawtooth pattern is buried in the QRS. Fortunately, once again, they gave us all these little circles down, or these blue dots here, so we know right where the flutter waves are. It kind of cheats a little bit, but you know, it kind of helps you identify what you're looking at. If you were to try to flip this upside down to find a sawtooth pattern, you almost see a sawtooth pattern. If we were to continue this here, you would be able to see a sawtooth pattern, but as you can see, the QRSs are masking that sawtooth pattern right there. This is another case, though, where I would do a 12 lead on this just because of the fact that this rhythm is fast. So let's go ahead and interpret this thing. The atrial rate, it gives us the little dots right here to tell us that these are actually flutter waves. So it kind of cheats for us, but we can go ahead and count that out. That looks to be just under 300. So we'll say 290 beats per minute. We also have our ventricular rate, which looks to be just over. This is our infinity. This is 300, 150, 100. So we'll say 130. You can count this out. That would be safer. I'm just estimating because I don't have any calipers on me, as you know. Regularity. Well, if we march it from the front side of the strip to the back side of the strip, I'm betting that this is going to be regular. But use your calipers and make sure. P waves are absent because there are F waves. PR interval is absent The QRS complex, while the rhythm looks ugly, you can tell the QRS is still quite narrow, and it's steeply angled and it's sharply pointed. So we're going to say 0.10 second. Here you have your F waves, which tells me that this is an atrial flutter. Because this is an atrial flutter, we have to figure out our conduction ratio. So we have 1 to QRS, 1 to QRS, 1 to QRS, and if you count that all the way across, you'll have with a 2 to 1 conduction. I like this rhythm because if you take this and flip it upside down, you can see a clear sawtooth pattern, I hope. It's pretty simple. As you look right across here, you can see the sawtooth pattern. So let me flip this thing back around and we'll interpret it. So let's look here. We have a trough right here and a trough right here. That is exactly 150, or 300. That's 300. That's 300. It occurs exactly on the 300 line. That makes it easy to count the atrial rate. The ventricular rate, it's irregular, which makes it difficult, so we should do a range. So what is our fast range? We'll start here, 300, 150, 100, so we'll say 120. Let's start here, 300, 150, 100, so 120. Now what's our slow range? We have to find the widest QRSs. Let's say this is right here, 300, 150, 175, so that's about 80. How about here? 300, 150, 175, so that's about 80. So we have a range of 120 to 80 beats per minute, or it should be 80 to 120, either way. Regularity is going to be irregular. The P waves are absent because there are F waves. The PR interval is absent because there are no P waves. The QRS complex, while that baseline looks pretty ugly, that QRS complex looks pretty good. Looks nice and narrow. Interpretation is going to be atrial flutter with a variable conduction. As you can see here, they notice that there is a recurring grouping that occurs. So what happens is you have a 1, 2, 3 to 1. This is actually a trough here, so you have a 1, 2, 3, 4 to 1. Here you have a 1, 2, 2 to 1. It's kind of a hard one to tell. 1, 2, 3 to 1. If you were to count all these out, what happens is you have this recurrent grouping that occurs. You could put this down up here as regularly irregular if you can find that grouping. I just put down irregular because it's not regular. It doesn't occur with a consistent conduction. Either way, you should be correct, but just be careful what your instructor wants you to do. The next one here, we also have some recurrent grouping, as you can see down there. First thing you want to do when you look at this and you see that weird baseline, you want to actually flip it upside down. You can do that right quick, and you can pretty easily now see the sawtooth pattern that is pathognomonic for atrial flutter. Now let's go ahead and do our atrial rate. We can do an atrial rate. It does exist because we do have atrial activity going on here. So we have from here to here, which is almost exactly 300 beats a minute. The ventricular rate is variable. So what is the widest ventricular rate we have here? That looks pretty wide, R to R. So 300, 150, 100. So it looks to be about 100 beats per minute to, what is our narrowest R to R interval? That looks like it. 300, 150. So that's about 140. Let me see here. 300, 150, 100. So maybe 140. So you have a discrepancy there of about 40 beats a minute, and I'm estimating here. So it's very possible that this is not that critical. The person's still in atrial flutter. You still need to work on fixing that. You can't just blow this off. But there's not as much of a range of your ventricular rate here. So it's not quite as bad as it could be worse, basically. So the regularity is going to be irregular. P waves are absent. because there are F waves. PR interval is absent because you have no P waves. The QRS complexes, they're kind of buried up here in some of these. This right here is not the QRS. It doesn't come all the way down here. It actually stops up here because this part here is the second part of the flutter wave. So if we find a QRS like this one right here that we can see a definitive starting and stopping, we can see that the QRS is about 0.08 second. The interpretation, since we have our F waves, our capital F waves, is atrial flutter. And it's irregular, and we don't have a constant conduction ratio here. So therefore, it's atrial flutter with variable conduction. Now let's start talking about some atrial fibrillation, the last rhythm we're going to discuss in the atrial rhythms. Atrial fibrillation is one of the most common arrhythmias that are found in the clinical arena. Very common, and most of the time with atrial fibrillation, there's no problem with it. A lot of people live long lives, long-ish lives, with chronic atrial fib, and I'll explain the difference between the atrial fibrillation. Basically, atrial fibrillation is a chaotic, asynchronous firing. And asynchronous, with this A in front of it, means out of sync firing of multiple areas within the atria. Most of the time what happens is the SA node is actually suppressed because of all of this electrical activity that is occurring in the atria. The SA node cannot take over as the primary pacemaker of the heart. Because of this fibrillation of the atria, there is very little to no atrial contraction, and this is a problem because if you remember, atrial contraction accounts for 20 to 30% of ventricular filling. So if you decrease this 20 to 30% of ventricular filling with no atrial contraction, you could potentially have a decrease in cardiac output. Fortunately, there are compensatory mechanisms within the heart to account for the lack of atrial contraction, but you definitely won't be as efficient as if you did have the SA node firing and allowing that atrial contraction. So in atrial fibrillation, you have this lack of atrial contraction, which results in a loss of the atrial kick, which I said is like the up to 30%. It can also cause the blood to stagnate or become stagnant in the atria. Now, any blood that's not moving, the clotting mechanism or the clotting cascade actually begins, and that's a bad thing. So what could happen is during this time of while you're in atrial fibrillation, if you're not on blood thinners or anything to prevent the clotting process, what's going to happen is you could start developing little clots or a big clot up in the atria, in the right and or left atrium. So whenever you have somebody that's in a chronic AFib, they need to be on some kind of blood thinners. If you have somebody that isn't in AFib and you just, oh my God, we have to convert them out of AFib, and if you convert them out of AFib and if they've started building some clots, you're now pumping clots either into the lungs or into the brain, depending on where it comes from, or to the rest of the body if it comes from the left side also. So this is a very dangerous rhythm if somebody is in it for a long time. There are three types of atrial fibrillation, something called paroxysmal, something called persistent, and something called permanent atrial fibrillation. I'm going to talk briefly about the difference between each one of these. First of all, paroxysmal AFib spontaneously converts back and forth between AFib and sinus rhythm. Supposed to be an arrow to sinus rhythm. So it actually converts spontaneously between AFib and sinus rhythm. And this could occur every few seconds, this would occur every few minutes, this would occur every few hours, it would occur every few days. Basically what happens is when it's paroxysmal, this means that it converts without pharmacology or electricity. Which means synchronized cardioversion. So if it goes in and out of AFib spontaneously without any kind of pharmacologic or electrical intervention, it's considered paroxysmal. Now, persistent, on the other hand, is a chronic AFib but it converts with pharmacology or electricity. So you have your persistent, which means it can't spontaneously come out of it by itself. It has to be pharmacologically or electrically stopped. And this is most of the cases where it's persistent. And a lot of people, they go on medications, or if they go into atrial fib for the first time, they can be cardioverted. It's a conscious sedation, and then they can sedate them and cardiovert them out of it. This is a majority of the cases. Unfortunately, there's a lot of people that end up in permanent AFib. And what that means is that this is a chronic AFib that cannot be converted. So it is an AFib that cannot be converted. And even if it is converted, it goes right back into it. You cannot get out of this AFib and stay out of this AFib. It is a chronic AFib. All they can do is give you some stuff to try to help improve your cardiac output by augmenting the ventricular force of contractions, or they just give you some blood thinners to make sure that you don't develop any clots. So that's the best thing that they can do for that. Those are the three different types of atrial fibrillation. So how are these F waves? And notice for atrial fibrillation, here's your lowercase f waves, not your capital F, because that's flutter. How are these F waves actually created in the atria? F waves are created by multiple depolarizations that occur in the atria. The areas here are each represented by a star that is actually considered an ectopic focus within the right atrium as it depolarizes. And I'm just using this right atrium as an example because it could occur across both atria. As you can see here, there's a star that depolarizes here, the pink, the blue, the yellow. Each one of these is a depolarization. Now what occurs in this is that as they run into each other, as these depolarizations occur, they occur very close in time to each other. They occur very rapidly. And as you can see here, as this red star depolarized, let's say that this green one here depolarized milliseconds after it did, as the wave of depolarization of the green star meets the wave of depolarization of the red star, what happened when they meet? It canceled each other out. Same thing with the pink. It canceled itself out. It ran into the blue. It canceled that out. The blue ran into the yellow, ran into the pink. Those ran out. Fortunately, the red was able to make it down a little further, so when the yellow star, which is another ectopic focus, depolarizes, it gets canceled out because it ran into that. Now, what we have here is all of these little wavelets that occur within the atria. But what's interesting about this is that each one of these little depolarizations here show up on the monitor. So what happens is you end up with a baseline that's very erratic because it's seeing all of these little depolarizations that occur. But what has to happen eventually is one of these waves has to get through to the ventricles. So in this case, you do have all of these little depolarizations here, which gives you the lowercase f waves that you can see on the monitor down here. And what happens is eventually one of these makes it through and will give you some type of QRS before you go back into this stuff right here. Now what these fib waves actually also can show you is that the atrial rate is quite chaotic. So there is no real baseline, but there's a very chaotic atria that are occurring right now. Unfortunately, you cannot determine an atrial rate in an atrial fib. You can't count this and say, well, here's one, here's one, here's one, here's one. You can't do that. There are so many depolarizations that are occurring up here in the atria that very commonly your atrial rate is actually somewhere between 400 to 700 beats per minute. So most of the time for an atrial rate, it's NA because you can't determine what it is. It's too fast to count. So what you end up with on a rhythm strip is a very irregular rhythm. There is no regularity to it except by coincidence. And in here, between these QRSs and these T waves here, you end up with this very chaotic bass line. These are the lowercase f waves, and the rhythm is all over the place. It could be really fast, it could be really slow, but the bottom line is all of these conductions that occur here never make it through the SA node. I'm sorry, never make it through the AV node until finally one of them does and gives you a good QRS depolarization, but you never know which one does it. So what you end up with is all of these different depolarizations that are trying to hit the AV node at the same time. And if there is any tissue in the AV node that has the ability to depolarize, it will start to depolarize. But eventually, and you can see the red one here, it makes it through all of these canceled out depolarizations as they hit each other. These are going to cancel each other out. The red one finally does make it through, and once it gets past the AV node, it's a very normal conduction. It's a very normal QRS complex because, like I said before, all of the problem are up here in the atria. Generally speaking, if the ventricular rate is less than 100 beats per minute, it's considered controlled. But if it's over 100 beats per minute, it's considered uncontrolled. And there's another one out there that is kind of loosely thrown around. If the ventricular rate is greater than 140 or to 150 beats per minute, it's considered AFib. It has a rapid ventricular response, RVR, rapid ventricular response. Let's look at the different types of atrial fibrillation that there could be. There's a fine AFib, and then there's also a coarse AFib, which there could also be down here. This would be considered a fine AFib. This is kind of an intermediate atrial fib. This is considered a coarse AFib down here. It really depends on the physiology of the person, the monitor you're using, the electrode placement. There's a whole bunch of stuff. The issue that we run into is that there are a lot of atrial fibs out there that are a very fine AFib, but people kind of get zoned in on something else and they actually don't see this even though they're staring at the rhythm strip, and they call this a junctional rhythm. The difference between atrial fib and junctional rhythm, if you can't see fib waves, is the fact that atrial fib is always irregular. A junctional rhythm should always be regular. So let's look at some characteristics of the atrial fibrillation. First of all, the atrial rate itself is... The atrial rate is going to be indeterminate. It is not absent. You cannot say it's absent because there is an atrial rate, but you can say that it's indeterminate. You can also say you can't count it or whatever. But bottom line is it's an indeterminate atrial rate because it's from 400 to 700 beats per minute, and you can't really count that on the rhythm strip. The ventricular is going to be variable. Now the regularity for atrial fib is going to be irregular. The P waves are going to be absent because there are lowercase f waves. The P to QRS ratio is absent. Now, unlike atrial flutter, there is no lower F wave to QRS complex ratio. There is no ratio there. It's just they're absent. The PQRS ratio is absent. The PR interval is absent because there's no P waves. The QRS width, it could be normal or wide, only because it's an atrial problem, not necessarily a ventricular problem as of right now. So let's start off with the first rhythm right here. This one could be very dangerous to try to interpret because the atrial rate is indeterminate. You don't have P waves. What's more dangerous is that people try to find P waves when they're not there. And if you can't see a clear, distinct P wave, you have to question, is there a P wave, and start looking at a different rhythm rather than trying like crazy to find that P wave, because you'll end up saying that this is a sinus arrhythmia. There's no P wave, and you get the whole rhythm wrong. So the atrial rate is indeterminate. The ventricular rate, you can see that it's irregular down here. If you get your calipers, you can see it pretty easily. But if you look here, let's look at our widest QRSs here, 300, 150, 100, 75, 60. So we'll say that our slowest rate is 70 beats per minute. It's supposed to be a 7. And our closest looks to be over here. This is 300, 150, 100, maybe 300, 150, 100. So our closest rate is 100 beats per minute, which gives me a 30 beat discrepancy right here. Not as bad as it could be, but still that's kind of a big range right there. The regularity is irregular. P waves are absent, which means there is no PR interval. Whoops. But we have P waves. Is everything absent? Well, no. Technically, there are fine fib waves, but it's really hard to tell here. I'm just going to put this because we're talking about atrial fibrillation. QRS complex, it looks a little bit wide. Let me see here. Starts here, ends here. So, nope, actually it looks good. 0.10 second. Looks a little bit weird, though. It could be developing something. Interpretation, because we have the lowercase f waves, we have Afib. If you wanted to be a rock star, you can call this controlled Afib if you wanted to, but you don't have to do that. The point is here, you'd have to look in another lead to find these fib waves. Looking at this next one here, we don't see any fib waves whatsoever. I've seen people take this right here and say, oh, well, this is a junctional arrhythmia. I've never seen that before. I don't even think that rhythm exists. Well, it may. But you have to look down here. This is kind of a hard one to tell, but let's go ahead and rock through this. The atrial rate is indeterminate. Ventricular rate, the widest is 300, 150, 100, 75, 60, so we'll say 65. The closest right here, 300, 150, 100, so we'll say 120. Pretty wide discrepancy right there. Regularity is irregular. P waves are absent. PR interval is absent. QRS looks almost a little bit wide. If you look over here, we have a definitive start here, a definitive stop here, definitive start here, definitive stop. Actually, you know what? 1, 2, that looks good. It looks narrow. So we have an atrial fibrillation. The next one here, the fib waves are a little bit easier to see, but it almost looks regular. Almost. But if you get out your calipers and march it, it's definitely irregular. So the atrial rate is indeterminate. The ventricular rate, let me see, 300, 150, 100, 75, 60. So we'll say that's about 65. That looks to be the widest one there. 2. That's about 75. 300, 150, 100, 75. So, no, that's a little bit northern. How about 300, 150, 100, 75? So that looks to be about 90. We'll say 90 beats per minute. Regularity is irregular. P waves are absent. And you can see a little bit better down here, these F waves. So they're lowercase F waves. PR interval absent because we have no P waves. QRSs, they do look wide. Let me start here. 1, 2. So they're right at 0.12 second. So they're borderline wide. I would still do a 12 lead on this because a person's in Afib and there's almost a borderline wide QRS complex. I'd want to find out why that is. Interpretation, controlled Afib. Here's another one where the fib waves, you can kind of see fib waves down here a little bit, kind of hard to tell, almost looks like a junctional rhythm, but there's another interesting thing about this. See how this QRS complex kind of scoops down into this ST segment, then back up into this T wave right here? That's actually called a digitalis scoop. This person has been on dig for a while. Whenever you start developing that scooping right there, that tells me this person's on dig. Being that this is an atrial fib, it doesn't surprise me that the person's on dig, because that's one of the common medications that we give patients who are in a chronic atrial fib or other chronic heart problems. So the atrial rate is indeterminate. Ventricular rate, we'll start out with our widest R to R. That looks like it right there. So 300, 150, 100, 75, 60, 50. So we'll say 46. That looks like our narrowest. We'll go 300, 150, 175. How about this one? 300, 150, 175. So that's closer. So we'll say 46 to 90 beats per minute. Regularity is irregular. P waves are absent because there are F waves, lowercase f waves. PR interval is absent. QRS complex. It's tough to tell because of the scooping right here exactly where the QRS ends. You just have to do your best to try to figure it out. That looks to be about 0.10 second. The nice thing about doing a 12 lead is that it would measure the QRS for you to really give you an accurate one, because it has the circuitry has a better way of determining the beginning and the ending of ventricular depolarization. So because we have our F waves here, we have a controlled AFib. Almost too controlled. I mean, look at that slow rate right there. Here's another rhythm where you can very easily see the fib waves, or you can finally see the fib waves. This is a clear atrial fib down here, as you can see this stuff right here. So our atrial rate, once again, is indeterminate. Ventricular rate, it looks to be, this is the widest, so 300, 150, 175, so we'll say 78. How about this? 300, 150, 175, so we'll say 75 is the slowest. And what's the fastest rate we have here? About 140, maybe 150. Huge discrepancy, 75 beats a minute right there. Fortunately, this is still fast enough where we don't have to worry too much about a dropping of a cardiac output, but it's still just interesting to note that there's a huge discrepancy in the ventricular rate between the slowest and the fastest. Regularity is irregular. P waves are absent because there are F waves. PR interval is absent. The QRS complex, let me see here, it looks pretty narrow, so 1, 2, so I'd say that's 0.08 second. Interpretation, atrial fibrillation. The next one here, still hard to tell, but if you look right here, you can see a few fib waves right there, so it looks like that this is going to be indeterminate. Ventricular rate, the slowest, is right here. 300, 150, 175, 60. So we'll say the slowest ventricular rate is 60 beats per minute. That's per minute. The fastest rate looks to be 300, 150, 100, so 120. Regularity, it's irregular. P waves are absent. PR interval is absent. P waves, we have a F waves. Remember, lowercase f waves. QRS complex is looking not too bad. Let me see. Find a good one that actually has a definitive starting and stopping. Here's one down here. We'll start here, stops here. That looks to be about 0.12. I think I went a little wide on that right here. So 0.12 second. Interpretation. is atrial fibrillation. This one here, I'm not going to go through the step-by-step process. You can do that pretty easily. This one here, you can very easily see this is a coarse atrial fibrillation right here. So once again, your atrial rate would be indeterminate. Your ventricular rate would be, you do the range here. It's irregular. There are no P waves. And this is all right here. This is all coarse atrial fib. So what you would say is just Afib as your interpretation, depending on if it's below or above 100, controlled or uncontrolled. But this right here, a lot of people see this and they try to see T waves and P waves in here, when in reality there are no T waves and P waves. The last one here, this would be an atrial fib also. It's kind of tough to tell. You can kind of see something in here. I would want to do a 12 lead on this right off the top of my head, I'm thinking, because of the rate by itself. Now, if an atrial rate gets really fast, an atrial fibrillation gets really fast, it's going to look like that there are regular QRSs, and it may be regular, and you have to slow it down. You'd still do a 12 lead, but you have to slow it down. But this right here tells me that this is probably an atrial fib. So this would be, I would diagnose this as an AFib with the rapid ventricular response, RVR, rapid ventricular response. Still do a 12 lead on this, but I would definitely want to find out what's going on underneath. I hope that you enjoyed this presentation of all of the atrial rhythms and how to interpret atrial rhythms. I apologize for the last couple rhythms, how I kind of rushed through them a little bit, but you can only look at so many rhythms before you finally say, yeah, I got it. If you have any questions at all, feel free to send me an email, or you can speak with your lecture instructor. I will also include a link in the information part of this video describing the video that will lead you to a website called Screencast, where you can download a handout to follow along with all three of these atrial presentations. Thank you for your time.